अस्सलाम वालेकुम डॉक्टर काशिफ, आप स्टार्ट करें।
वालेकुम सलाम सर, आवाज आ रही है आपको?
जी
सर शराइस आवाज आ रही है ना आपको?
जी आवाज आ रही है, आप स्टार्ट करें।
सर अस्सलाम वालेकुम everyone. I am Dr. Kashif Sarfaraz, resident neurosurgery, and as we all know, we are today going to discuss something about the middle cerebral artery aneurysm. Before starting or going towards the aneurysm, let's discuss a little bit anatomy, theory, and as well as few diagrams. MCA artery is basically terminal branch of the internal carotid artery, and it's a part of anterior circulation, and it's one of the most important arterial structures and most important location or the anatomical surgical anatomy of the significance is that it travels from the base of through the lateral sulcus or the Sabian fissure before terminating into the lateral surface. So the importance of Sabian fissure is quite nominal in the MCA aneurysms. So MCA is basically divided into 4 segments, and each segment has its different arteries. Number one is the M1, or that is called a sphenoidal segment, because the M1 segment begins at the terminal bifurcation of the internal carotid and ends at the genu, and it is a right angle, makes a right angle bend as it courses over the small gyrus of the insular cortex, that is called the lamina insulin. And this M1 segment is named it runs parallel to a sphenoidal ridge, so that's why it is called the sphenoidal segment of the the MC artery. Next is the M2 segment or the insular segment. This insular segment begins at the genu. It runs in the insular cleft and terminates at the circular circles of insula, where the arteries make the next right angle turn. Third is the opercular, and the fourth is the terminal segment. I will detail the details that more good in the next slide. So, so it supplies it to the anterior commissure, to the internal capsule, to the orbital surface of frontal lobe, inferior and middle frontal gyri, and superior part of the lateral surface of the occipital lobe. So this is a very good diagram. That is a coronal view of the middle cerebral artery. As you can see, the 4 segments are quite visible, and we can study the surgical anatomy. You can see this is the internal carotid artery, and it is terminating at the middle cerebral artery, and is running uh, parallel to a sphenoidal ridge here. And before bifurcation into superior and inferior segments, it is giving branches that are called the lateral lenticular striate arteries. Next, this is the insular segment of the M2 that you can see over this part. The middle cerebral artery M1 segment is giving 2 bifurcation, or sometimes it is giving trifurcations. So this is the superior and inferior trunks, and this M2 part, it's the insular segment, which is beginning at the genu, and it is running into the insular cleft, and this is now continuing as the part of continuing into the central sulcus, and may be exerted by 90 to 180-degree turn. The third one is the opercular part. This is the M3 part after again running from this genu, and this is making a 90-degree turn. This artery is present in the opercular segment, and it is giving also a different branches. It leaves the insular surface. It runs towards runs the opercular cleft and terminates at the cortical surface of the retrovagal brain. And this M4, these are called the cortical branches, or the extreme branches of the middle cerebral artery. And this M4 segment of the lateral aspects of the cortical segment, it is sometimes giving 3 or 4 right angle branches that are supplying the lateral hemispheres of the brain. So the MC artery courses through the Sylvian fissure from the ICA terminus, all right, and goes and terminates to a lateral convexity. It has got four segments. It has got two trunks and some two bifurcations, and it's or makes a three right angle bends and branches and gives different branches at each side. This another good diagram. We can see identify this is the internal carotid artery. This is the M1 segment. These are the two bifurcations, and this is the M2 segment. It is continuing as the M3 segment in the Sylvian fissure and in the obstructor segment. And then this is the fourth segment. These are right angle arteries that are branches of the or the continuation of the M4 segments of the middle cerebral artery. This is the same diagram. You can see in the Sylvian fissure it is making a 90 to 180 degree turn, this MC artery, and then giving branches towards the deep structures of the brain. Now coming towards the middle cerebral artery aneurysms. These are one of the most common aneurysms. There are 21% of all the cerebral aneurysm identified or discovered. The first common aneurysm is the ACOM, interior communicating artery aneurysm, which is 40%, and the second one is the ICA, that is 30%. So the 80 to 85%, but the literature, the 80 to 85% of the MCU aneurysms, they occur at the M1 and M2 bifurcation. And in sometimes it's known as if it's a thrombose or giant aneurysm at Sylvian fissure, it is called giant serpentine aneurysm, which is most commonly or commonly identified in the segments. You can see, yes, some literature said 80 to 85. These are the most the location of the aneurysm. This is the M1 segment, and before divided condition as a M2 bifurcation, this is the most common area, which is just this literature is showing 63%, and some of the books says 80 to 85%. 18% are at the first terminal branches of at 18%. At the ventricular striate artery, there are 13%, and after at the M3 segments, it is usually 6%. So this is the area that is more eloquent and more important as the common site of MC aneurysm. So how do we classify this MC aneurysm? We classify according to morphology and size. If the size is less than 5 millimeter, it is small, medium 5 to 10 millimeter. If it is large, it is 11 to 25 millimeter. If it is giant, it's greater than 25 millimeter. According to morphology, aneurysms are classified into different types: secular aneurysms, fusiform, breast aneurysm, and extremely breastmorphic or infectious aneurysms, which are most commonly present in the M4 branches of the MC aneurysm. Uh, Coming to identification, we have got three different basic modalities. If a patient comes to us with loss of consciousness, altered level of consciousness, headache, severe headache, uncontrolled, and we are suspecting a subarachnoid hemorrhage due to any aneurysm, especially in young patients, we categorize the radiology basically into three types. We get a normal CT brain plane to see if there's a subarachnoid hemorrhage present or not. We get a CT angiogram and digital sensitive angiography or MR angiogram to identify the type and the location of the exact aneurysm. CT scan is just for the subarachnoid hemorrhage. You can see that this is the part of M2 segment, and there you can see hyper dense area. This is the left MC, this is the right MC. This is part of the M2 segment. At the bifurcation, we can see there's a hyper dense area, and along with subarachnoid hemorrhage that is showing something at the level of MCA. And I'm sorry, this is not a clear image, but it's just a T1 weighted image of MRI. You can with contrast, and you can see there's a small hyper intense lesion at the following the middle cerebral artery. This is a fat stratified image. Again, there's a hyper intense lesion. It's not a good image. I'm sorry. So these are the important images that are the MR angiograms or ESAs, which are mainstay in diagnosis of the location of the aneurysms and the patency of the parallel or branching arteries and the course of MCA. So if we look at the CT scan, we identified that there's a aneurysm that has been following. We've identified a hyperdense area. You can see if we look closely, this is the area we were talking about. This is the axial section, the ICH, and this is the M2 segment. This middle cerebral artery. This is the M2 segment, which is not quite maybe clear to some seniors, but for juniors, I will explain them on sagittal sections. This complete network of arteries form the complete circle of Willis, and you can see, yes, this is the radiological image, that this is the right, this is the right MCA, and carotid artery. This is the MCA. This is before going into a part of M2 after contention M2 segment. This is a lobulated structure at the just the M2 superior trunk bifurcation. There is a secular, you can see a sort of hyper dense lesion. Yes, this then comes the uh, coronal image, which is quite clear. We can see there is a secular aneurysm or giant aneurysm at the M2 segment. This is the carotid artery. This is M1, and this is the M2 segment, which is particularly contained in M3, and these are the M4 segment that we were talking about. So this is the M2 segment, which has a lobulated structure of that we can see that aneurysm. The left side is patent. There's nothing significant can be identified. Okay, this was a case of image of a young patient of 40 years old who had again this sector aneurysm at the M2 bifurcation, and and how do we see the patency of the middle cerebral and the other parallel arteries. You can see this is the IC again. This is the condition MC. This is the lenticular striate artery, and again you can see a component. And uh, after balloons, after the coiling, the size of the aneurysm has been significantly reduced, and the patency of the arteries can be seen normally. This is the right MCA. This is the left MCA, and that can be followed. So coming towards the one important slide, that whenever we are talking about coiling or clipping versus generally in coiling, whether we should do coiling or clipping in any sort of aneurysm, uh, these are basically inclusion and exclusion criteria of coiling and clipping. Normally the MCA aneurysms are giant, and they're bigger in size, so uh, preferably clipping uh, is the mode of treatment in these patients. So when we do coiling, if the patient is elderly, 475 years old, it has got poor clinical grade or inaccessible ruptured aneurysm, the important is the dome to neck ratio, which is greater than or equal to 2, or absolute neck diameter, which should be less than 5 millimeters. So in these patients, we'll go for coiling, and these are most commonly done in the posterior circulation aneurysms. And when we go for clipping, we generally, for younger patients now, the trends have changed. The endovascular surgery has advanced quite a lot, so many people are going for coiling of the aneurysms. uh, MC bifurcation aneurysm difficult to access for coiling have a broader neck, so clipping is preferred um, in these patients. Again, the size is greater than 20 millimeter, as the patient may have symptoms due to mass effect, or sometimes if there is very small aneurysm, then that the coiling cannot be done, or the clipping can be easy, like if the diameter is less than 2 millimeter, clipping is preferred. And obviously, if we talk about the wide neck and broad neck, so coiling, the slippage of coiling or dislodgement of the coils are an easy complication that are seen. So clipping is preferred. And or if the patient they have come with failed coiling or residual failing after the coiling, so clipping is done in these patients. Right. Coming to the management of these patients, any patient coming with aneurysm should be at least should be admitted in a monitoring setup, and preferably at least an HDU. Should be managed on the line of subarachnoid hemorrhage. Can be given triple H therapy. Have to keep the blood pressures high, keep in hypernatremia and hypervolemia to keep the optimal blood pressure. We'll do the baseline investigations and manage conservatively till we have signs, and if we have signs of, or if we are thinking of vasospasm, we can do serial scans and looking at the daily report of the patient if the labs are normal and the patient is optimal for surgery and for better outcomes. So optimal time of surgery would be 7 to 14 days, keeping the line of subarachnoid hemorrhage. So we are today discussing about the MCA aneurysm, and we are focusing mainly on clipping. So I have included how to approach an MCA aneurysm, the surgical steps. Before clipping, there are certain principles for aneurysm clipping. There are certain principles. You should have a wide craniotomy, should have an adequate exposure, maximum sharp dissection should be done, and there should be visualization of both the proximal and distal ends of the artery, and there should be proper visualization of neck and the parallel arteries. The surgical, if we go for surgical management, most common is the pterional approach, and clipping is done for both ruptured and unruptured aneurysms. The factors that are included at the patient age, the general health, clinical presentation, smoking history, and that all the pre-op workup before fitness, and aneurysm, what is the size of aneurysm, what would be the size of the clip uh, that would be applied, and this should be done accordingly before we are moving for the surgical procedure. So this is the standard position, supine position when head tilt on the opposite side, uh, uh, and with 30 degrees 30 degrees rotation on the opposite side, and clean head shape should be done. This is the typical pterional incision, the frontotemporal incision that we are familiar about. So after we are exposing the pterional part, we go for cerebral craniotomy. You can see I'm just quickly moving toward this part because the other steps are quite important before we are moving towards the aneurysm, how to expose in this. So after this removal of the bone flap, this comes the important part, that is the sylvian fissure. And you can see the cortical veins and arteries. Uh, in this diagram, we have made a D-shaped incision in the dura, and we have to identify both the frontal and temporal lobes, and most important, the sylvian fissure, and with the cortical veins have to identify, and we have to go on this plane to identify and detect the M1 segment, and following the segments of the middle cerebral artery and reaching up to the aneurysm. So sylvian fissure is the most important part, as I said. There can be different types of sylvian fissures. As you can see, uh, there is an atrophic fissure, there is an opposed fissure, there is a frontal herniating fissure, and temporal, and this is the temporal herniating fissure. Because we have to approach in between the two lobes, frontal and temporal lobe, so we need to see the pre-op scans as we are talking about the age of the patient, and sometimes you can see atrophic patients, they are most commonly present in older patients and with minimal contact between the frontal and the temporal lobe. In the opposed fissures, they are common with large areas of contact between the frontal and temporal lobes, and there are interdigitated sutures, fissures, and or maybe one of them is herniating. You can see the frontal then becomes the frontal herniating fissure or the temporal herniating fissure. They're basically tightly opposed with each other in areas of contact, and the approach must angle of approach must follow this contour before reaching the middle cerebral artery. So this is a very important diagram. We have to identify the sylvian veins and the we have and the sylvian arteries and this because all our dissection lies in this the sylvian fissure. All right, these are the frontal and the temporal lobes, and dissection is in splitting the splitting first the splitting of the sylvian veins and then making a deep sharp cortical incision in the arachnoid plane and then accessing the middle cerebral artery. We can identify this is the aneurysm at the M1 and M2 by the two bifurcation. So we have to clearly identify for the sylvian veins, and we have to ligate and cut uh, away from the aneurysm so the exposures can be done easily. Second comes after identifying the sylvian veins and ligation cutting of sylvian veins. When we have to identify the course of the MCA. After identifying, there can be two types of arteries which are patent. Number one, that's if we look at this, the A arteries may be supplying only on one lobe that are easier to access, and sometimes the arteries are making an angulated turn supplying both the lobes. So we have to identify and do the sharp dissection in these arteries because why? Because we have to go either from the distal or the proximal approach. So we should know the patency or the supplying arteries of the inferior and the superior trunks so that the patency of the arteries cannot be compromised to prevent the post-operative complications. Right. This diagram shows the location of the aneurysm according in the upward plane in the post and the coronal plane. You can see the M1 sometimes makes an upward arch, and there's a down inferior tilt of the aneurysm. Sometimes it is a superior tilt. Sometimes it is the lateral tilt. You can see in the axial views. This is MCA, and it is having posterior tilt, or sometimes it is having anterior tilt. So if we look at the coronal section, we will see at uh, the inferior these type of tilts because the dissection from this arachnoid the plane is important. We have to separate this aneurysm from these adhesions so that the ligation at the neck can be done easily. So this is the these are the most important step in the dissection of the aneurysms, because we have entered deep down into the brain and we are now going for the dissection of the aneurysm. The most common is the distal to proximal dissection. Uh, there are different steps. You can see the step one is to follow these are the step one is following the superior trunk. All right, from distal part going proximal to the neck, identifying, preparing the M1 segment for proximal control. All right, the step three is following the superior trunk from the inner surface. The step 4 is then following the inferior trunk again from inner surface from the other side, and then finally reaching the neck of the aneurysm. aneurysm and applying the clip of over the neck of the aneurysm. This is the most common approach that is generally considered to get the control of the aneurysm. The other thing that can be done is the proximal control. In this, you can see uh, it starts from the proximal segment of the IC. We are following the IC, number identifying the A1 segment of the internal carotid artery. Number three step is identifying the ACH laterally and dissecting, following following the dissection plane, following the dissection plane towards the aneurysm, and gaining more proximal control. Next step is identify going following again from the superior trunk and shifting to the the distal civil fissure along the superior trunk, and then reaching towards the aneurysm neck. The number seven step is following the inferior trunk from the inner surface, and then finally dissecting the distal neck and applying the clip over the aneurysm. This comes with experience, and this is done in 20 to 30% of the Third one, the uncommon approach is sometimes the superior temporal gyrus approach. This approach is applied when we do not have a clear access through the Sylvian fissure. It is most commonly done in the ruptured bifurcation aneurysm. If we come across complex venous anatomy of the Sylvian fissure, and maybe a temporal lobe hematomas are associated because of the ruptured aneurysm. In this, a 2 to 3 centimeter cortical incision is made in the anterior aspect of the superior temporal gyrus and parallel to the Sylvian fissure. And their subpyral dissection is carried out medially. And the MCA branches are then followed proximally. Again, we have, again, after the dissection of the subpyral region and identifying the vertical segment, with MCA branches are followed proximally and described previously. The steps come back as per the previous section. And then the other arteries, the ventricle striate, and they should be identified because they are quite important, and we may not accidentally clip the artery instead of uh, having clip the main area of aneurysm. And it should be enough area, enough exposure along the MCA trunk, so that the temporary clip is applied if the dissection or the if the approach is difficult while reaching the main aneurysm. Uh, there are some clipping principles. The broad-based thick neck aneurysm may require temporary clipping to deflate the aneurysm and facilitate proper permanent clip application. And we should ensure there's adequate closing force along the aneurysm neck. Or maybe sometimes a fenestrated clip is applied to obliterate the distal neck, followed by a parallel permanent clip to occlude the proximal neck. This is done in thrombose or atherosclerotic aneurysms or giant aneurysms. Uh, there are different types of clipping techniques. There are simple clipping, there are multiple clipping. Clips are used for broad necks or multiple aneurysms. There's a tandem clipping in which it is the aneurysms usually are in larger size, and simple clipping cannot be applied easily. And the last is the angle fenestrated clipping, in which there are calcified segments, or there are other parallel arteries that are involved, or there are atherosclerotic thrombosed aneurysms where the simple clipping can be difficult. So in this part, we are applying the angle fenestrated clipping followed by permanent clipping. This is a very good diagram. This is a typical MCA aneurysm normally, and we are the aneurysms. They are simple. We have already seen they are not folded. This is a special MCA simple clip, and they are used with small, simple, and narrow neck aneurysms. And you can see they are you can see this blade. Uh, you can see this blade. This is perpendicular to the efferent arteriole and parallel to the efferent arteriole. Perpendicular to the if perpendicular to the efferent and parallel to the efferent arteriole, and which we have to identify before clipping of the aneurysm. As you can see in the gross structure, yes, this is a example of the right angle clip that was applied uh, of the aneurysm. And you can see before the efferent arteriole, this is the efferent, this is the 90 degree, and then coming to the efferent, this is parallel to the efferent arteriole. So this is a very good diagram that is showing the clipping of the simple clipping of the aneurysm around the neck. So every procedure has some complication. There can be anesthesia complications as well as if we talk about surgical complications, there are intraoperative rupture. They can be bleeding. Patient can have vasospasm. They can be late complications like dislodgement of clips. Patient can have seizures. The patient can have hemiparesis post-operatively if the clips are not applied or the segments are compromised, and if patients can have visual field defects as well. These are some of the common complications that are associated with clipping techniques. So just some surgical pitfalls. Sometimes we talked about the rotation of head that was 30 degrees. So overrating of head causes temporal lobe to overlie the salient fixation. So a greater temporal lobe retraction is required and difficult can cause difficulty. Overextension is also not required. Maybe it causes because it causes obstruction of view by orbital rim, and opening of the dura is quite important because the aneurysm can be aneurysm can lie superficially, can be attached to the dura, and if there's any visible stenosis at the M2 and M1 or M2 arteries, the clip placement should not be accepted because it is frequently associated with severe luminal constriction. And very importantly, the confirmation of the vessel patency that should be made at pre-operative or intraoperative angiography with or ultrasound probe measurement, so that we do not post-operative phase vasospasm, seizures, or hemiparesis as we have discussed previously. Thank you so much.
Okay, a nice presentation, Kashif. Mostly MC aneurysms are very common aneurysms, and mostly they are bleeds. And like you mentioned, that the most common site of the bleed is the aneurysm is the M1 M2 bifurcation, because this site is having the more mechanical pressure and the shear forces of the blood. So this is the most common site of the aneurysms present in the territory of the middle cerebral artery. But distal aneurysms are also present, but they are usually small in size, and it's very challenging to identify these aneurysms. And the other, there is some important points regarding the identification of the MC aneurysm, that if a patient is present with a subarachnoid hemorrhage and we are suspecting that patient is having any aneurysmal rupture, so there are some points which are favored that might be this is a rupture is because of the middle cerebral artery. One thing is that the patients who are present with the fits, and we are suspecting the having patient is having the rupture of an aneurysm, then the most of the patients who are present with the fits, then they have the ruptured aneurysm of the MC artery. And the other thing is that if a patient presents us and he is unconscious, and the CT scan is suggesting that patient is having a ruptured aneurysm of any location, then again 60% of the patient of the MC artery rupture are present with the fits, or sorry, present with the unconscious state. Then again, another thing is that if a patient who is awake and he is having the hemiparesis, and his uh, his CT scan showing that he is having a ruptured aneurysm, then again this could be the MC aneurysm ruptured. And one thing more is about that about 1/3 of the patients of the MC aneurysm are present with the unilateral headache. This thing is again in the favor of the ruptured MC aneurysm, and the headache is most likely toward the site of the rupture. And thing is that patient of the MC and ruptured aneurysm have the focal neurological deficit. This is because of the presence of the blood in the subarachnoid space plus intra brain parenchyma as well. And if a patient who is having the intracerebral hemorrhage in the which is in the frontal lobe as well as in the temporal lobe and is bridging the sphenoid ridge, this is a diagnostic sign of the MC aneurysm rupture. कोई और ऐड करना चाहेगा पॉइंट्स सीनियर्स में से कोई?
Hello.
जी बोलें.
I just want to add a few things. First of all, since MC aneurysms are present, these aneurysms of the MC artery, they're present more laterally. So when you're surgically approaching an MC aneurysm, it is technically a little bit more easier than approaching an ACOM aneurysm because they're much deeper inside. Another point that when you're clipping any aneurysm, whether it be an ACOM aneurysm or an MC aneurysm, certain things that you should keep in mind. And these are the principles of aneurysm surgery basically. So before starting the surgery on any aneurysm, you must have a detailed plan of the surgeon. For that, pre-op assessment and workup is of critical importance. The blood pressure should be kept low, at least 20% below the systolic pressure. And when you're applying the pins, a local anesthesia should be used to prevent rising the blood pressure during the surgery. If a spinal drain is used, then whenever you're opening up the dura, the drain can be used to decrease the intracranial pressure. And then you also have to give mannitol. When usually that is done when you're making your first spur hole. Mannitol should be given to relax the brain. Pterional craniotomy is the main approach that we use for approaching an MC aneurysm. The craniotomy should be large, so there's more space to work, and it also provides more room for relaxation. And then when you're selecting clips in the aneurysm, you should make sure that temporary and permanent clips are present. And then the main thing is to find the internal carotid artery. And then you make space for the temporary clips. And when you find the internal carotid artery, you can also gain the proximal control. So proximal control of the vessels to the aneurysm as well as distal control of the vessels from the aneurysm should be initially, we should expose these areas before working on the aneurysm itself. Then after that, when you're dissecting, when you're doing dissection to find the neck of the aneurysm, because that is where you apply the clip, the neck is the strongest part of the aneurysm because it is the thickest wall histologically. So the aneurysm should be, the dissection should be done at the base of the aneurysm and the neck, that area. And then barbiturate protection is sometimes used for temporary clipping as well.
Anyone else?
Alishan, Nadia.
Hello, Assalamu alaikum.
Walaikum salam.
As others have mentioned about the MC aneurysm, we should first see the anatomy. Anatomy is from the internal carotid artery, and there are few segments, M1 segments, M2, M3, and as you have already told that most of the aneurysm are present at the bifurcation of the M1, M2, which is called a trifurcation, which is not the true trifurcation, but it is called the trifurcation. And there are 2-3 approaches, as Rabel has said, the pterional approach, which is the most common one, and there are other superior temporal gyrus approach. So this
ये कंट्रोल हमें मिल सकती है हमारे पास, ये कर्सर आप लोगों को नजर आ रहा है ना, ये कर्सर आप लोगों को नजर आ रही है ना?
जी सर.
अच्छा देखिए, एमसी एन्यूरिज्म वो वाला देखा है जो पहले वाला था, वो देखा है. अच्छा. जो MC aneurysm है, it is superficial, quite near to the surface as compared to the other one. अगर आप देखते हैं तो MC aneurysm बिल्कुल बीच में है, जहां तक जाने के लिए काफी ब्रेन अटैक करना पड़ता है. So that is why surgery is the first preference in case of MC aneurysm as compared to the other one. क्योंकि dissection कम करनी पड़ती है. अब इनमें अगर आप देखिए, if aneurysm is here and that ruptures, तो बिल्कुल सरफेस करीब पड़ता है, इसलिए इन लोगों में सबड्यूरल हेमाटोमा भी होता है. ये सुपीरियर फ्रंट टेम्पोरल गायरस इज वेरी नियर, और अगर ये रप्चर होता है, दैट कैन एंटर इनटू द गायरस एंड द पेशेंट कैन हैव इंटरपेरेन्काइमल ब्लीड एज कंपेयर्ड टू द अदर वन आप देख रहे हैं. अच्छा, जो M2 की जो सेलिन फिशर की तरफ जा रहे हैं एन्यूरिज्म, ये बड़े होते हैं क्योंकि स्पेस ज्यादा है. समझ आ गया ना? तो इसमें ये थोड़ा सा डिफरेंट है फ्रॉम द अदर एन्यूरिज्म्स, बट इट इज नॉट सो कॉमन. आप देख रहे हैं हमने कितने MC एन्यूरिज्म देखे, बहुत कम है. एकॉम इज वेरी कॉमन, वेरी वेरी कॉमन इज एकॉम. उसके सेकंड नंबर पे ये आता है. एकॉम तो मेरे ख्याल में बहुत कम होते हैं. अब यहाँ पे एन्यूरिज्म है इधर, तो इसके लिए तीन रास्ते हैं. या तो हम ट्रांसिल्वियन आ जाए बाहर से, या ट्रांसिल्वियन आ जाए इनर साइड से, या ट्रांसपेरेन्काइमल आ जाए. तो ट्रांसपेरेन्काइमल शुड कम व्हेन देयर इज इंट्रापेरेन्काइमल ब्लीड. उसमें आप जाए, ब्लीड भी एस्पिरेट कर ले, और यहाँ पे आपको आसानी से एन्यूरिज्म मिल सकता है. ट्रांसफिल्वियन बाहर से आने में ये है कि आपको पहले एन्यूरिज्म सामने आता है, प्रॉक्सिमल कंट्रोल उसको बाद में आप लेना होता है. इस वजह से आपको जरा प्रॉब्लम होती है. अगर आप इनर साइड से आते हैं सेलिन फिशर से, दिस इज जस्ट लाइक जिस तरह हम एकॉम एन्यूरिज्म करते हैं. अपने फ्रंटल लोब रिट्रैक्ट करें, यू विल रीच टू द मीडियल साइड ऑफ द सेलिन फिशर. आप वहां से स्टार्ट करें और कम लेटरली. अच्छा, इसमें एक और डायग्राम था जिसने दिखाया था सर्जिकल साइड पे था. एक ये वाला, ठीक है. ये सेलिन फिशर को बाहर से खोल रहा है बंदा, ठीक है. तो देखिए ये जो फाइबर्स है जिसने दोनों अपर्कुल आपस में मिलाया हुआ है, यहाँ पे ट्रांसवर्स है, लेकिन यहाँ पे वर्टिकल फाइबर्स है नीचे. आप समझ आ रहे हैं ना? ये देखिए, ये फाइबर्स दीज आर अलोंग द लेंथ ऑफ द सेलिन फिशर, लेकिन दे आर क्रॉसिंग द सेलिन फिशर. जब इसको आप काटते हैं, ये छोटे छोटे ब्रांच होते हैं वेन की, ये बहुत ब्लीड करते हैं, इतना आसानी से नहीं होते. बट एंट्री शुड बी towards the frontal lobe in respect to this vein. ये vein जो है ना, it is more adherent to the temporal lobe. जब आप इसको अलग करते हैं तो patient can bleed. इसलिए आपने इस vein के frontal side पे जाना है. जब आप अंदर जाते हैं, ये उसने उधर से लिया ना, ये 7 एन्यूरिज्म से, तो आपको पहले फॉलो करना है the vessel which is towards the frontal lobe. उसके थ्रू जाएं, आप एन्यूरिज्म तक पहुंचे. लेकिन जब आप पहुंचे तो आपने वापस नहीं आना, अपनी प्रॉक्सिमल कंट्रोल की जगह आइडेंटिफाई करनी है. फिर आप वापस उसके साथ साथ, जब फिर अदर ब्रांच, क्योंकि दो ब्रांचेस हैं, बाइफर्केशन है, फिर इसके साथ आए, वापस आ जाए, फिर इसके साथ जाएं, दोनों साइड पे. लेकिन इस तरह जो एन्यूरिज्म यहाँ पे होता है मिडिल सेरेब्रल आर्टरी में, इसके साथ काफी सारे ब्रांचेस होते हैं, इसलिए उनको अलग करना इज नॉट सो इजी. लेकिन इसको अलग करना जरूरी भी है. इसलिए यहाँ के जो क्लिप होते हैं वो बिल्कुल एंगुलेटेड क्लिप लगते हैं. इसमें आप वो स्ट्रेट वाले क्लिप्स इसमें नहीं लगा सकते. जब आप लगाएंगे तो यू विल क्लिप नॉर्मल ब्रांच एज वेल. इसमें बेटर टू फॉलो द फ्रंटल साइड ऑफ द वेन. When you enter into the saline fissure, follow the frontal side of the artery, reach to the aneurysm, identify the and look at the proximal control area, then come back and follow this vessel. और इसके नेक को बिल्कुल अलग करते जाए, फिर आप एन्यूरिज्म क्लिप अप्लाई कर सकते हैं. सो ये काफी कॉम्प्लेक्स होता है. इसमें वेसल से अलग करना इट्स नॉट इजी. कभी कभार कोई वेसल आपको लेना पड़ता है ये क्लिपिंग के दौरान. सो एनीहाउ इन एनी एन्यूरिज्म प्रॉक्सिमल कंट्रोल इज मस्ट. सो दिस कंट्रोल कैन बी either we can go from lateral to middle or from middle to lateral. हेमाटोमा में आपने ट्रांससिल्वियन जाना होता है, लेकिन उसमें ये है कि उसमें कंट्रोल जरा मुश्किल हो जाता है प्रॉक्सिमल. बस ये तीन अप्रोचेज हैं. वन इज ट्रांससिल्वियन एंड वन इज ट्रांसकॉर्टिकल. ट्रांसलेशन कैन बी फ्रॉम लेटरल टू मिडिल और फ्रॉम मिडिल टू लेटरल। मिडिल टू लेटरल में हम ये M1 आसानी से मिलता है, इसलिए हमारी कंट्रोल आसानी होती है। लेटरल टू मिडिल में आपको डायसेक्शन ज्यादा करनी पड़ती है, ट्रांससिल्वेनसली इसमें ब्लीडिंग ज्यादा होती है। और बिफोर गोइंग टू एनी पाथवे वन शुड नो अबाउट द सिल्वियन फिशर ऑफ दैट पर्टिकुलर पेशेंट। वो कैसा है, आसानी से खुल सकते हैं नहीं है, वरना ब्लीडिंग होती है, क्योंकि एडिशंस होती हैं, और जब आप वो एडिशंस रिमूव करते हैं तो इतना आसानी से नहीं होता। जो ही आप इंसर्जन क्या कहते हैं उसको, जो वो है फोर्सेप या कोई भी चीज आप टच करते हैं, पेशेंट ब्लीड करता है। और सीजर जो है ना, माइक्रो सीजर जब भी आप टच करते हैं ब्लीड करते हैं। सो इसमें ये वेन के आइडेंटिफिकेशन, ब्रांचेस के आइडेंटिफिकेशन और ट्रांसलेबल कंट्रोल, दीज आर मस्ट। वन शुड नो अबाउट दिस थ्री अप्रोचेस, ट्रांसलेबल, either middle or lateral, or transcortical. So transcortical is selected when there is endocrine parenchymal bleed. और इस superior उस दिन वो बंद भी कह रहे थे कि middle और temporal में superior temporal wires उससे जाना होता है। So इसमें अगर coiling और clipping हो तो clipping is better as compared to coiling, क्योंकि dissection कम करनी पड़ती है। लेकिन अगर neck वाला issue हो तो इसमें फिर कॉइलिंग भी करते हैं, लेकिन यहाँ पे अक्सर ब्रॉड नेक वाले होते हैं, ब्रॉड में वैसे भी क्लिपिंग करनी चाहिए। सो एमसीए के एन्यूरिज्म में लोग प्रेफर करते हैं क्लिपिंग बिकॉज ऑफ द इजी डाइसेक्शन। ठीक है, यार ये पेशेंट खराब ना हो जाए, इसको मैनेज जरूर सब्जी वाली कल आई थी मेरे पास तो हो रही थी, ये इन्वेस्टमेंट